Head projection, skull. This video shows the instruction of the skull anterior-posterior projection. The skull AP projection uses vertical collimation to the glabella with the SID value of 100 centimeters while the respiration is suspended and allows the examination of fractures and bony lesions of skull and facial bone. For skull AP projection, the patient is placed in an erect position, sitting position, or supine position with the mid-sagittal plane of the head aligned to the vertical axis crossing the center of the image receptor. Then flex the cervical vertebrae enough to align the orbitomeatal line perpendicular to the image receptor and lean the occipital region gently on the image receptor and place the nasion at the center of the image receptor. When the patient is placed in a supine position, use the support device like pillow would aid the perpendicular alignment of the orbitomeatal line to the image receptor. If the patient cannot flex the cervical vertebrae, use 7 degrees collimation in caudal direction to the nasion with a perpendicular alignment of the orbitomeatal line to the image receptor. If both of the above two methods are impossible due to the patient's condition, use parallel collimation to the orbitomeatal line without forced posture. Skull AP projection should include the entire structures of the skull between parietal region and mandible. Upon the evaluation of skull AP projection, the petrous ridge should stack over the superior orbital margin, and the bilateral petrous ridges should be aligned symmetrically where the skull should not be rotated. Frontal bone, ethmoid sinus, nasal septum, crista galli, and other facial structures should be clearly observable.